Welcome back. Today we're going to be discussing Chapter 12, which covers the primary assessment. The primary assessment is part of your larger patient assessment. It comes right after your scene size up. And if you remember back to Chapter 11 when we talked about the scene size up, scene size up should only take a few seconds. That should be as you're walking up to your patient. You should be able to gather most of that information right away. Then we want to go immediately into our primary assessment. The goal of the primary assessment is to identify life threats immediately so we can take care of them. So that's what all this chapter is going to be about. It is another relatively quick chapter, so we should fly through most of this material, but it is vital to know and vital to do properly. If you don't do the primary assessment immediately, that's where patients can die on us. So we'll dive right into the primary assessment. Like I said, your primary assessment's job is to try to identify life threats. So the three things that we are going to be looking at in the majority of the primary assessment are your airway, your breathing, and your circulation. They are abbreviated your A, B, C's. A for airway, B for breathing, and C for circulation. So just remember that you're looking for your ABCs, and we're looking for any life threats that affect your ABCs. The primary assessment varies quite a bit depending on your patient's condition. If you have an unconscious patient, you're going to adapt to try to figure out if you have any life threats to these areas based off of what you see and feel, versus if you have a conscious patient who's talking to you, you can knock out a lot of these things just by them talking to you. For example, and we're going to get into it, but for example, if someone's conscious and talking to you, one of the steps that we look at in the airway is making sure the airway's open. If someone is talking to you, as you remember back from our airway section, if they're talking, they have an open airway. So you can check that box off saying, yes, my patient's airway is open because they're talking to me. If someone's unconscious, then we aren't really sure if their airway is open. So we have to go into a deeper assessment mode and look, listen, and feel for air movement in and out of the lungs and getting out of the mouth to ensure that there's no obstruction there and that the airway is in fact open. And then your primary assessment can also vary if you find life threats. Sometimes you might find 2 or 3 life threats that you have to take care of, and sometimes you might be the only EMT on scene who can take care of a life threat. So you might have to prioritize which threat is a higher priority to you. So it does vary based off of patient condition, but for the most part, your ABCs and your primary assessment stays the same. So your ABCs, the order that we do them will change based off of the patient is essentially alive or not. If they have signs of life, like you obviously see that they have movement or they're obviously breathing, then we want to stick with the ABC order. So ABC would be checking your airway first, making sure it's open, checking your breathing status second, and then checking your circulatory status third. If you feel like they might not be alive or they aren't showing signs of life, then we switch the order around to form CAB, CAB. That's where we're checking our circulatory status first, then we're following it up with our airway, then our breathing. The reason behind that is we want to make sure that they actually have a pulse first, because if they don't have a pulse, then we need to be jumping straight into chest compressions with CPR rather than wasting another 10-15 seconds looking at your airway and breathing before we find out if you have a pulse or not. Usually when we find issues in our ABCs or CABs, you want to stop and fix immediately. So any major issue in here is typically renders an immediate intervention. Minor issues, not so much, we can bypass those, but major issues we will fix immediately. And we'll discuss how to identify major issues. So when we're talking about the airway being open, if you find in your assessment that there's vomit in the airway, we know from our airway section that any vomit in the airway will go down into the lungs, and that is usually fatal, if not very, very, very serious. So if we find any vomit or blood in the airway, then we need to take care of that immediately and stop that life threat. So that is one of the, we see it, we fix it immediately steps. Another one that we can encounter a lot is a arterial bleed, so copious amounts of blood that we see coming out. That is a life threat. If you lose too much blood, then you are going to be out of blood in your body and you can't transport oxygen. So if we see a heavy, life-threatening, typically arterial bleed, that's something that we are going to stop and fix right then. That's different from someone who is just bleeding a lot if it has a nice slow ooze to it. So they might have 100 cc's of blood that they've bled out, which looks like a lot, but it's a slow bleed coming out. That's something that can wait a minute or so for us to make sure the rest of our life threats are taken care of. So that's a big decision that you have to make, is what things that you encounter in here are serious enough for you to treat immediately before you move on to any other step. And typically, we're looking for something that is going to immediately cause the patient to either die or be very seriously disabled. So if you see something that will very quickly cause a deterioration of the patient, that's typically the things that we are looking to fix in the primary assessment. Anything beyond that, we go to our secondary assessment, which we'll talk about in another chapter. So during your primary assessment, if you look over everything and you decide that CPR is not needed and mechanically breathing for the patient is not needed, there's no airway obstruction, and there's no major bleed, this is where we start to administer oxygen depending on the patient's condition. So if you find that oxygen administration is warranted for the patient, the primary assessment is where you would do that. You do prioritize that lower than things such as CPR or stopping a very fast bleed that's happening or obstructed airway. So we want to fix those things first before we give supplemental oxygen, because those are much higher life threats than getting a little bit extra oxygen into the body. So keep that in mind. Oxygen is administered during your primary assessment, but it's one of the lowest priority things that we do. So make sure that the patient has a pulse and is not going to bleed out and does not have a obstructed airway first. So your whole primary assessment section, and you can find this on your New York State assessment sheets, right below scene size up, you're going to have your primary assessment. And the order that you're supposed to do this is you form a general impression of the patient. General impression is what, from your initial look, what you're seeing and what you're thinking. A lot of times we call general impression sick or not sick. If you look at the patient and you think, wow, they are in serious medical trouble, that's our general impression. If you look at a patient and they look like you and me sitting in a chair, they don't look to be in obvious distress, that is your general impression of the patient. Next thing that you want to assess is their mental status. Their mental status is just a quick, how is their brain doing? Are they alert? Are they like you and me, just sitting there talking to us? Are they only alert if I talk to them and they suddenly open their eyes, but then they close them again because we aren't talking, we're stimulating them? Do they only move if I'm giving them painful stimuli and they'll just kind of move towards that painful stimuli and groan? Or are they not moving at all? After we form our general impression and we find our mental status, that's when we go into our ABCs. We assess our airway, we assess our breathing, and we assess our circulation. Then after all of that, we have enough information to determine, is this patient in danger or not? What is their priority? Are they a high priority patient that they need immediate intervention and they need to get to the hospital immediately? Or is this a lower priority patient where we can kind of take our time doing a very thorough assessment and doing some treatments on scene and taking our time moving the patient? So this is where we should have enough information to make that determination adequately. So let's revisit forming your general impression. Like I said, the general impression is when you walk into a house, you say, "Hi, my name is Paramedic Buskey. This is my partner. What's going on today?" And your general impression should be formed from the first couple words that they say. If they say words, you know they're at least alert and talking to you. This is where you might see that they're having significant respiratory distress. This might be where you see that they're unconscious. So this is where you just have the general impression of what am I seeing, and the first couple words that come out of my patient's mouth, if they can speak, tell me what. So that is your general impression. General impression should also morph into getting a chief complaint. That's why when I say what's going on today, they'll usually say, oh, my chest is really hurting. Right there, the first few words out of the patient's mouth, I now have a general impression of the patient's at least conscious. They can talk and understand me, and I know their chief complaint is chest pain. It also takes into account their appearance. Are they sitting there and they have nice, warm, dry skin, it's good color, or are they sitting there and they're sweating profusely and they have pale skin or blue skin and they look like they're really struggling to breathe? That's your appearance that will go into your general impression. Do they look like they are sick? Do they look like they're in trouble? Or do they look like they're kind of okay? They can wait a few minutes. So that's the purpose of our general impression, is to take all that information and help us guide where we're headed in this call very quickly. It'll help us determine our patient severity and help us determine how much time we need to spend on our ABCs. It'll help us set our priorities for care and transport. So this is our first initial look to tell us how bad is this patient doing. So again, we call this the look test because this is formed from our first sight of the patient as well as the first couple of words with the patient. So this is something that we should be forming as we are walking up, and then we can sometimes combine it with what they first tell us. So they've emphasized it being a look test because they want this to happen very, very quickly as you are approaching your patient. So taking a look at this picture, you are walking up to this patient without saying a word to them because it's a picture. What are some things that you see? So right here, she's holding her knee. It looks like a little bit of blood there, so probably has some pain. You see a small head injury right here. She's looking off. She doesn't look happy, and there's toys right here. So your general impression is she's looking, so you know that she's conscious because she's looking. She has some minor injuries, so we know that this is probably a traumatic call and probably a call with knee pain and head pain. And it looks like she is probably playing and got hurt. She may have tripped on one of her toys and fallen down. So as you're walking up, all this information is coming towards you, and you can start to form your general impression. The general impression of this patient is, are they going to die in the next couple minutes? Doesn't look like it right now. So this would be a lower priority patient, but someone who still has injuries and someone that we're going to need to treat. So this is all stuff that we can form in the first couple of seconds as we're walking up. That's why the general impression is huge. Again, your general impression helps identify patients who may be critical. The entirety of primary assessment, as its purpose, is to identify critical patients. This is where we're going to be seeing if someone is obviously has altered mental status, that where they are obviously unconscious. This is where we can decide whether or not we're doing ABC or CAB in our primary assessment. This is where we can decide that. When you first see them, do they look like they're alive or not? Some other things you might want to look for are obvious traumas to the head, chest, abdomen, or pelvis. Those are all critical areas to have obvious trauma. So that might tell you that you need to focus on circulation first, because they might be having some massive bleed. If you see someone who is shot to the chest and they have blood spewing out of them, that's where we can say, okay, I see obviously we're losing a lot of blood. Let's treat that first, then come back to our airway and breathing. This is also where, as we're approaching, we might be able to see how the patient is positioned. If you remember back to breathing, we saw people who are in the tripod position. So that's leaning forward, usually your elbows are on your knees, and you're kind of gasping for air. That's a common sign of someone who's having significant respiratory distress. And this is where we might see Levine's sign. Levine's sign is the stereotypical chest pain position that you see people in. It's where they take their right arm and they cross it over their chest and they're like clutching at their heart. That is a instinctive thing that humans do when they're having a cardiac event, is holding their chest just like that. So that's something that we can see in our general impression. And if you see that, you'll have the general impression that they're having a cardiac event, which could be life-threatening. So moving on into your chief complaint. Your chief complaint is going to help guide the rest of your call. It's finding out what's going on with the patient, why we're there. So like I said, when I approach most patients, I'll introduce myself and my partner, and then I will immediately say what's going on. That's me both working on my general impression and me trying to obtain my chief complaint. So I've already done my scene size up as I'm walking up. As I am approaching the patient, I'm doing my general impression, which is completed by me saying what's going on. Some patients are very good at answering this. They'll say, oh, my chest hurts, oh, my head hurts, my stomach hurts. Some people will just be like, I just don't feel good. And so that's when you have to try to be a little bit more specific and be like, well, what doesn't feel good? Because my not feeling good could be different from your not feeling good. My not feeling good is usually my stomach hurts, I feel nauseous, but your not feeling good might be I have a cold, I'm having a cough that's really persistent. So that's where we need to try to be a little bit more specific and ask more direct questions besides just saying what's going on. We can say, well, do you have chest pain? Does your head hurt? Is your breathing okay? So most patients are usually good with a chief complaint, but this is just a very quick, you want to know exactly why we're there. So this is a quick, what's going on? Oh, my stomach hurts. Okay, I know my chief complaint. Let's move on. We'll then revisit this complaint and assess it much more thoroughly in our secondary assessment. So when you're getting your chief complaint, you want to do your own assessment too, especially if they can't talk to you. So look to see their age, their gender, and what position they're in. So for a chief complaint, if I'm come up and I have a patient with chest pain, and so I say, what's going on? They say, I have chest pain. I can say, I have a 52-year-old male who is sitting talking to me and says that he has chest pain. That is my chief complaint / general impression. Okay. If you have someone who is not talking to you very well, if they're unconscious or semi-conscious, that's when we start to listen for some cues. If they're moaning, they might be in pain. If they have snoring respirations, we know that they might have an airway obstruction. Or if they have gurgling respirations, we know we might have someone who needs a suction out of the airway. So that can be part of your chief complaint is you walk up and you see an unconscious male laying on his back on the ground with snoring respirations. So you know that being unconscious is your chief complaint, and you probably have a life threat to the airway. Some other cues that you can help determine your chief complaint, especially if they can't talk to you, is smells. So a lot of patients that might have a UTI will have a strong urine smell. A UTI is a urinary tract infection. They'll have a strong urine smell to them. Some people who have a gastrointestinal bleed, so they're bleeding inside their GI tract, they will have a strong odor of feces, and there might be feces all over the house because it's continually coming out of them. Or you might have someone who's vomiting a lot. You can smell vomit and see vomit around. So all this can help determine your chief complaint, especially if the patient can't talk to you. So once we have our general impression and our chief complaint, we want to determine their broad mental status. And most of this can be done, all three of these can be done in the simple walking up and saying, what's going on today? That's how quickly these three things should be knocked out. So the mnemonic that we use to remember alter or assessing mental status is called AVPU. 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 So AVPU is how we broadly organize our mental status. You and me talking right now, that is alert, so A on that scale. If someone is alert, that's where we can get a little bit more specific and we can find out what they are oriented to. So oriented to is making sure they know the right answers to certain things. So 3 things that we look for, and it's really 4 things now. We want to know if they're oriented to person, so they know who they are. So you can say, what's your name? And if they respond appropriately, they're oriented to person. Place, so knowing where they are. So if say, where are you? And they say their house, they're oriented to what place they're in. Time, so you can say, what year is it, or what month is it, or what day is it, or what day of the week. And if they respond appropriately, then they're oriented to time. And then the other thing that's been added in is being oriented to events. So common events that everyone should know. One of the most common ones that we use is who's the current president of the United States, because that is something that does change every 4 to 8 years. So it is a event that most people in this country should know. So if they are alert, you can find out, are they alert and oriented to person, place, time, and events. If they are not alert, you need to find out how altered they are. So the V in AVPU stands for verbal response. So that's someone whose eyes are closed, they don't respond to you as you walk up, and you say their name or you say hello, and they open up their eyes and they can talk to you, but then when you stop stimulating them by talking to them, they go back to sleep. This is different from someone who is just sleeping and you wake them up. If someone's sleeping and you wake them up, then they have a whole conversation with you and they're fine after that, that's different than this. This is someone can't stay awake unless you are talking to them and they are actively talking back. Then they close their eyes again. So that is a verbal response. Below that is a painful response. So you walk up to someone, their eyes are closed, they're not moving, so you know they are not alert. You talk to them, you say their name, they don't respond, so they are not alert to verbal stimuli. And so this is where you give them a little bit of painful stimuli. You do something that will cause a little bit of pain to them. One of the very common things we've used in the past is a sternum rub. That's where we put our knuckles into someone's sternum and rub up and down. We're going away from that in medicine, mainly because we don't know if that patient's had open heart surgery or any sort of damage to their chest. We don't want to aggravate that. So sometimes we can kind of shake their shoulders, or if we want to inflict a little bit of pain, putting something into their nail bed, so their fingernail bed. Anything that will provide just a little bit of painful stimuli to the patient. And if they wake up to that, so they open their eyes, they groan, they swing at you, anything like that, then they are responsive to that painful stimuli. This doesn't mean that their eyes open up, which they might, but if they are moving around, so their body is stimulated by that pain, then they are responsive to painful stimuli. If you do all of that and they aren't moving at all, they aren't not opening up their eyes, they're not talking, they're not moving, they don't flinch to painful stimuli, then they are the U, which is unresponsive. So AVPU stands for alert, alert to verbal, alert to painful, or unresponsive. And you want to be at A, and working your way down is a deteriorating patient condition. So that is AVPU. That is something that you guys are going to have to know. So your primary assessment, again, will vary depending on your patient's condition. You might do ABCs or you might have to do CAB depending on how you find the patient in your general impression. And also, your primary assessment, if you find someone who is awake and talking to you, so you know that they are alert, and then you go into making sure that they are oriented as well. While you're doing that, you are checking off knowing that, again, they have an open airway. If they're talking to you and they seem to be talking just fine, probably their breathing is going to be somewhat okay. You might still have to treat the breathing, but it's probably not going to be a life threat if they are talking to you normally. And also, if they are alert and talking to you, chances are their circulation is going to be okay, because that's something that they can verbalize to you. That if you are alert and oriented, you will know if you have a massive bleed going on in your body. So just talking for the first few seconds will help you determine how critical your ABCs are, and will help you determine what order we're doing these in. If someone's unconscious, that's where we start to determine, are we doing circulation first, or are we doing airway or breathing first? So again, all of your primary assessment, it's meant to identify and treat major life threats. These are things that are going to kill you quickly. You also will gather some information that helps you in your secondary assessment, such as your chief complaint. That's going to help you in your secondary assessment to focus on a body system that the chief complaint is focused on. So those are the goals that we're doing in our primary assessment in our ABCs. So taking a look at this picture, what is your general impression of this patient? So this patient is laying supine on the ground. He doesn't look like he's responsive. You can see the EMT by his head is touching him, so he's going to be assessing for responsiveness. If he is unresponsive, that's where we are going to say that he is not showing signs of life right now, unless if you see his chest going up and down. But if you don't, that's where we find in our general impression in the first couple of seconds that we need to do our circulation first. So we need to check to see if he has a pulse first. So this is how quickly all this goes. It's a very, very quick process. In reality, your scene size up and your primary assessment should happen in 10 to 30 seconds. That's as long as we are spending on this, because we can find most of these answers very quickly, and we're supposed to, so that we can treat them very quickly. So like I said, when we're assessing our airway, if the patient is alert and talking to you, or they're crying, that means that air is going in and out from their lungs through their vocal cords and out their mouth. So that means that they don't have an airway obstruction. It means that the airway is open. If you find that it is not open, so they can't talk, they are not moving air, this is when we need to take immediate action. So if you find someone that is not moving air in and out, so this is where we assess to see if the chest is rising or not. If the chest is not rising, we assume that we do not have a patent airway. That's where we do our head tilt chin lift, and we can put in an OPA or an NPA to help this airway stay open. So this is when we're assessing that and we're taking care of it. Moving on into breathing. So breathing is, we know the airway is open or not. Now we need to know how well they are actually breathing. Are they breathing at all? This is where we find this out, both in your airway and your breathing. So you listen real quick. You aren't listening to find what type of lung sounds the patient has, but quick listen to see if air is actually moving in and out. You can also feel the chest. Is the chest rising or not? So this is where we see how well is this patient doing. This is where you refer back to section 2 with our airway management and think of all the signs of inadequate breathing. So this is where we find, is this patient failing in breathing? And if they are, this is where we treat them immediately. So we can give them oxygen. This is where we can suction the airway if needed. This is, if you didn't do it already in your airway assessment, in breathing, maybe you need to put an airway adjunct in to help them breathe. So this is where we are treating any major thing that we're finding that indicates that the patient is in respiratory failure, or will be very soon. This, if I didn't say it, this is also where we're giving oxygen to our patients. So we can give them a non-rebreather at 15 liters per minute of oxygen. If we have to ventilate the patient with a BVM, this is where we're doing that with 15 liters per minute of oxygen. So this is where our oxygen administration should happen to the patient. Then moving on into circulation. There's 2 or 3 big things that you want to check with your circulation. You want to check your skin condition. So if the skin is warm, pink, and dry, that indicates that we have good circulation happening. So that is a normal vital sign, just so you know when we're checking skin. Warm, pink, and dry is what we're looking for. Any deviation is usually not good. If someone's in shock, they typically will have pale, clammy, and cool skin. So it'll be what we call diaphoretic, so a lot of sweat there. It's going to be cold to the touch because the sweat's evaporating, and it's going to be pale. The reason behind this is in shock, all your blood wants to come back to your core so that it's going through your vital organs. Your body doesn't care if you keep your hand or not, or your arm or not, when you're in shock. It wants to make sure that your vital organs are going to make it through this event. So all the blood is summoned back there. So if blood's not near your arms or your legs, that's where you're going to be pale because you don't have the pink of the blood flowing through it enough. It's going to be cool because blood is what provides our body heat, and it's going to be clammy because all of your sweat glands are going to release. So that's something that we see in shock. It's usually an indication that the patient is not doing well. So skin is one of the 3 things we need to check with circulation. So the second thing that we are checking for is pulse. We are not checking the rate at this point. We are just checking, do they have a pulse? And is it, we usually check at the carotid if they're unconscious. The carotid is the pulse right by the neck. And we do that because the carotid will maintain a pulse longer than your arms or legs will. So those are called your peripheral pulses. Your carotid is a central pulse. So we are checking on the carotid for someone who is unconscious, and we just want to know, is it present, and is it beating really, 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 really fast, or really, really, really slow? And is it strong, or is it weak? So is it bounding against your fingers, or is it really hard to feel? So that's the second thing we check for. So first thing is skin condition. Second thing is pulse. And then the third thing is for severe bleeding. And when I say severe, I mean severe. I mean blood that is coming out at you. Like I said before, the little ooze that, it could be 100 milliliters of blood, which looks like a lot, but it's just oozing out. That's not what we are looking for in this stage. We're looking for the stuff that is spurting out of you, is coming out with some force behind you. And if you find that, that's where we control it. Typically, that means that we're going to be putting a tourniquet to wherever the bleed is to stop that bleed from happening. So after you've done your general impression, your chief complaint, your ABCs, you should have a decent idea of how sick this patient is. You should know, did you find any life threats? Did you treat any life threats? Do you think any life threats are going to come up soon? So this is where we can find that, are they sick or are they not sick? Are they going to die soon or are they going to be okay? And that goes into your determination of how high of a priority this patient is. Now, just because you determine a patient is low priority from your ABCs doesn't mean that you might find something later on that will make them a higher priority. In order for them to be a low priority, for example, you need to have vital signs that are within the normal range, or maybe just a little bit outside of the normal range. So if you find a patient that your ABCs don't reveal any life threats, but then you take their blood pressure and their blood pressure is 80/60, first off, you should probably find that in your primary assessment because your pulse will probably be weak and the patient's skin will probably be cool and clammy and pale. But if they aren't and their blood pressure is that low, they are not going to be fully stable. So that's when you can upgrade and say, okay, this patient now has a higher priority. But you found that out in your secondary assessment because we're not taking vital signs in your primary assessment. So this will give you a good idea of the priority of the patient, whether high or low priority. But this isn't the end all be all. This is why we have our secondary assessment. This is just designed to catch the common major life threats. So if you find any life threats that you treat or find any life threats that you can't treat, automatically this patient is going to be a high priority patient. So like I said, there's a lot of times when it's not cut and dry what the patient's problem is, especially if they're unconscious and you can't talk to them. So you don't know what their full chief complaint is besides being unconscious. So be very flexible. And a patient might go from being high priority to low priority. For example, if you have someone who is a heroin overdose and they are unconscious and not breathing, that is a high priority patient. But then you treat them by giving them Narcan, and all of a sudden they are completely alert, they're oriented, they're breathing on their own. They went from a very high priority patient because they're unconscious, not breathing, to a lower priority patient. They still are a priority because they were unconscious and they weren't breathing. That can cause a lot of damage to your brain and a lot of damage to your heart. But it's a little bit less life-threatening when they are awake and breathing on their own. And that's a change that will happen after your primary assessment. So be very, very fluid. Understand patients' priorities can either get better or they can get worse. So when you're identifying your priority, if this is a high priority patient because they have a life threat, this is someone that you want to transport immediately. You want to transport them immediately, and you want to be transporting them on a priority. So you're using your lights and sirens. You're trying as best you can to get the patient to a higher level of care. This is not where you want to sit on scene for 10 minutes to wait for a paramedic to come help you. This is where you put the patient in the ambulance and you tell the paramedic to find you on the way to the hospital. So this is where we determine, no, we need to load this patient up and get going and find a good place to meet a higher level of care on the way to the hospital, or sometimes the hospital might be your highest level of care. This is also where we don't do our secondary assessment on scene. We say this patient is a high priority. We're getting them in the ambulance now. I will do the rest of my assessment while we are transporting this patient. I'm going to do the rest of my interventions while we're transporting this patient. So again, understand patients can change on us. So just because they are a low priority initially doesn't mean that something's not going to change. They'll make them a high priority later. So at any point, if you find a patient as a high priority, that's where you need to start transport immediately and try to rendezvous with a higher level of care on the way. So think about how normal findings in a primary assessment might differ for a child compared with an adult. So remember, in your primary assessment, you want to know if they're breathing, and then you want to know if they're breathing really fast or really slow. You don't want to count respirations, but you just want to know, is it really, really fast or really, really slow? Because that helps to tell you if it's effective or not. So in a child compared to an adult, if you remember in lifespan development, we talked about children's respiratory rates are much faster than adults. So in your primary assessment of a healthy infant, for example, they're going to be breathing 40 to 60 times a minute, depending on how old they are. And that is normal for them versus a adult, if they're breathing 40 to 60 times a minute, that's so fast that it's not effective for them, so they don't have an adequate airway. So that's something that will be normal in a kid, but not in an adult. So we do have to tailor our assessments based off the age. And that's why we talked about lifespan development. That's why we're going to talk about pediatrics, or I'm going to talk about late adulthood and all that stuff, because that will help us guide our assessment and tell us what's normal for this patient, which might not be normal for another patient. Okay, so moving on to some chapter review. Like I said, this is a very quick chapter, but it is crucial. This is where we are saving lives of our patient, is in our primary assessment. So it is very critical that you have this stuff down pat. So the primary assessment is a systematic approach to quickly finding and treating immediate threats to life. The general impression, although subjective, can provide extremely useful information regarding the urgency of a patient's condition. The determination of mental status follows that AVPU approach. Evaluating airway, breathing, and circulation quickly but thoroughly will reveal immediate threats to life that must be treated before further assessment. Your approach to a patient will vary depending on how they present. The AHA recommends a circulation, airway, then breathing approach for patients who appear lifeless and apparently are not breathing or have only agonal respirations. This begins with a pulse check and chest compressions if there is no pulse. If your patient shows signs of life, such as if they're moving, moaning, talking, and is breathing, you take your traditional ABC approach. So CAB is only if you think the patient might not be alive. Remember that the mnemonic ABC is just a guide to interventions that may be taken. You will choose your interventions based off of what you find on each individual patient's immediate needs. They may be done in any order that fits the patient's needs. So this is why the general impression will help guide your care. The patient's priority describes how urgent the patient's need to be transported is and how to conduct the rest of your assessment. Remember, determine if a patient is responsive or unresponsive, whether the patient is an adult, child, or an infant. Rapidly identify the need for immediate airway intervention. Determine if the patient's condition is stable enough to allow further assessment and treatment at the scene. So think about what factors will you take into account in forming a general impression of the patient. Again, this is what we see when we're walking up in the first couple words. So this is the very quick, do they look like they're in trouble or not? Are they sick or not? This is what you are seeing will help you form your general impression. How should you assess a patient's mental status with regard to the AVPU levels of responsiveness? So remember, A stands for alert. So if someone's talking to you when you walk up, that's how you determine they're alert. That's when we go into are they oriented to person, place, time, and events. V is for verbal. So if they aren't looking up at you when you walk up to them, you say their name. If they look up, but they immediately go back to sleep or they look back down, and then they don't talk to you until you stimulate them again with verbal stimuli, that's V. P is if they only move or open their eyes to painful stimuli, and U is completely unresponsive. How should you assess airway, breathing, and circulation during the primary assessment? So this is what we spent a few minutes talking about. This is stuff that should be going very quickly, and use clues from your assessment to help you, such as if they're talking to you, you know that their airway's open. If they're not, you want to be feeling for their chest rise. You want to be listening for air movement. You want to find out, is their respiratory rate really fast or really slow, or does it seem to be normal? You want to find out, do they have a pulse? Is it really fast or really slow? Is it strong? Is it weak? How's their skin doing? Do you see any major bleeding happening? And what is it meant by the term priority decision? So that is when we are deciding how sick is this patient, how quickly do we need to transport them. A middle-aged man is lying on the street after being hit by a car. He appears unresponsive as you approach. You notice he is bleeding from a laceration on his forearm and is making gurgling sounds from his airway. If you are alone, what factors do you consider in deciding what to do first? Why? So if you're alone, remember you only have two hands, so you will only be able to take over one aspect of patient care. So you need to find out, does he have a pulse? If he has a pulse, great, you don't have to do CPR. If he doesn't, that's where you're doing chest compressions, because keeping that blood moving around is a higher priority. If he does have a pulse, you can move on into airway and find out, is he breathing? If he's not breathing, that's where we take over our airway, and that's what you're stuck doing. If he is breathing but he has an obstruction that you need to suck out because he has gurgling respirations, that's where you need to do that. So that's where you prioritize. We need blood moving around first, then we need air moving, then we need the right amount of air moving. So those are your priorities, especially if you're alone. So that brings us to the end of this chapter. It's like I said, relatively quick chapter, but this is very important for us to know. This is something that in calls, if you combine scene assessment and primary assessment on the vast majority of calls, this should be done in the first minute. On critical calls, this is where we want to be stopping and treating, and this is where we're actually saving lives, is in our primary assessment. So it's very important to know, and we're going to be practicing it over and over and over again with our patient assessment stations for our practical.